So I've got medicine residents here with me today. So we'll be discussing about hypokalemia and its approach. So firstly, Shivaji, can you tell us about the clinical presentations of hypokalemia?
Yes, sir. There are four clinical presentations in hypokalemia, sir.
Okay.
First one is symmetrical ascending paralysis, sir,
Okay.
involving respiratory muscles. And
Okay.
second one is muscle cramps with high colored urine seen in rhabdomyolysis, sir.
Okay, very good.
And third one is colonic pseudo obstruction, sir.
Okay.
And fourth one is polyuria seen in diabetes insipidus, sir.
Okay, very good. So also, can you tell us about the ECG changes that we commonly see in hypokalemia patients?
Yes, sir. To see an ECG changes, the potassium levels must be less than 3 milliequivalents per liter, sir.
Okay.
And on ECG, the P wave amplitude will be increased and
Okay.
PR prolongation will be there, sir,
Okay.
along with ST segment depression.
Okay.
And there will be prominent U waves in hypokalemia. Due to this prominent U waves, there will be fusion of T wave and U waves,
Okay.
which will cause QT prolongation, that is apparent QT prolongation, sir.
Okay, okay, very good. Okay, Manias, how do you approach this case?
Rule out pseudo-hypokalemia, sir, secondary to delayed sampling analysis
Okay.
or significant leukocytosis.
Okay.
Then rule out hypomagnesemia, which
Okay.
can cause a disruption of sodium-potassium ATPase pump, and also Romco channel activation leading to hypokalemia.
Very good.
Then look for any transcellular shift of potassium,
Okay.
like beta agonist drugs usage, insulin, hyperthyroidism,
Okay.
or familial hypokalemic periodic paralysis.
Okay, very good. Okay, so how do you proceed further?
Sir, after above causes are ruled out, we need to check for potassium loss.
Okay.
We need to evaluate for potassium loss. To differentiate renal and extrarenal like GI causes, we'll go ahead with SWOT urine potassium to creatine ratio.
Okay.
If it is less than 1.5, it could be GI causes like
Okay.
VIPoma, laxatives, or diarrhea.
Okay, good.
If it is more than 1.5, it is renal causes.
Okay, but there are so many renal causes of potassium loss.
Yes.
So how to proceed further?
We'll check for BP. If patient is hypertensive, it could be secondary to hyperaldosteronism, Cushing's, and Liddle's.
Okay.
If the patient is BP is normal or hypertensive, we'll go ahead with ABG.
Okay.
If ABG shows acidosis, it is DK or RTA. If
Okay.
it is alkalosis, it is Gentleman's Barter's
Or diuretics.
or
is it?
diuretics.
Okay. So this is how we should evaluate a patient of hypokalemia. Now we'll learn how to go ahead with the treatment. So Srimai.
So to treat, first we have to see the severity of hypokalemia, which
Okay.
is mild to moderate if the serum potassium levels are between 2.5 to 3.5. If there are no symptoms or ECG changes, then we correct by paroral route,
Okay.
wherein 15 ml of potassium chloride is equivalent to 20
Okay.
milliequivalents, which we give 2 to 4 times in a day. If it is severe hypokalemia, wherein the serum potassium level is less than 2.5 milliequivalent, then we go with IV route as well as paroral route. Via IV route, if it is a peripheral line, then we correct 20 milliequivalents per hour. If it is a central line, then we can go up to 40 milliequivalents per hour. Alongside, we give paroral potassium chloride 15 ml 2 to 4 times in a day. And we do not correct more than 160 milliequivalents in a day.
Okay. That was a good summary. So can you guys tell us how much potassium increase is expected after giving 40 milliequivalents of potassium? Do tell us in the comment section below, and thank you.